It is an intra-abdominal process causing severe pain, usually less than 24 hours. Often it requires surgical intervention when it is a surgical cause. Usually requires immediate judgment or decision to keep a fruitful management. The problem of acute abdominal pain is that sometimes it needs operation and sometimes doesn't require intervention. If I operate and the problem is not surgical, the patient is exposed to unnecessary risk of surgery and of anesthesia. And if I don't operate and the problem is surgical, the patient is at risk because of wrong therapy. Several factors can modify the expression of pain. As the extreme of ages, young age and old age, if there is vascular compromise to the intra-abdominal structures, if there is pregnancy, and if there is CNS pathology, the pain usually less than should be, and if there is neutropenia. Abdominal pain from any cause is mediated by either visceral or somatic afferent nerves, as we know. Because of the complex dual visceral and parietal sensory network subserving the abdominal area, pain is not well localized as in the extremities. We have two types of pain, visceral pain and parietal or somatic pain. The stimuli that cause visceral pain are distension of the gut, traction on bowel mesentery, inflammation, ischemia, and sensation correspond to the empirological origin of the diseased organ. Visceral sensation is mediated by afferent C fibers located in the wall of the viscera and is stimulated by distension, inflammation, ischemia, stimulating the receptors. Visceral pain is slow in onset, dull, poorly localized and protracted, usually felt in the midline due to bilateral sensory supply of the spinal cord. If we have a case of acute appendicitis, usually we say that the pain started very umbilical because this is T10 and the appendix is supplied from T10. Sometimes it is to the right, sometimes it is left of the midline because of the bilateral innervation of the intra-abdominal organs. This in contrast to somatic pain, which due to irritation of the peritoneum. Whenever we have appendicitis, we say that the pain is midline or periumbilical, and this is the visceral pain of appendicitis. When the inflammation of the appendix reaches the parietal peritoneum, the pain becomes localized in the right side of the abdomen, and this is the somatic or parietal pain. This pain is sharp and localized well, easily described by the patient, and the pain is associated with rebound or absent bowel sound. Parietal pain, by contrast to the visceral pain, is conducted through C and A delta fiber, giving more acute sharper pain sensation only to one side of the nervous system, not to bilaterally as the visceral. We have also something called referral pain. This denotes noxious cutaneous sensation at a site distant from the strong primary stimulus. Sometimes you have patient having acute cholecystitis and he is feeling the pain at the tip of his right shoulder. This is a referred pain. It is due to confluence of afferent nerve fibers from widely different areas within the posterior horn of the spinal cord. Spreading or shifting pain. Pain started at a site, then becomes localized at another site, as we said, like the appendicitis. It started in the periumbilical area and then become localized in the right iliac fossa. It is due to irritation of the parietal peritoneum. It is due to recruitment of the receptor. What means of recruitment of receptors? At early stage of inflammation, a small number of receptors become stimulated. When it is increased due to increased inflammation, it is localized, and we call this recruitment of the receptors, And if there is fluid coming out from the inflamed area, we put this fluid gravitation, and this gives rise to parietal pain. There is many types of onset and progression of pain regarding the visceral pain. It is maybe explosive within seconds, and this occurs in torsions. If we have something like torsion testis, torsion ovary, the pain occurs in seconds. It may be rapidly progressive within an hour, and this case of acute appendicitis, acute cholecystitis. And the gradual in mesenteric vascular thrombosis, the pain starts gradual due to progression of the thrombus. Pain character. It is very steady pain in most common cases, grabbing, mounting pain of a small bowel obstruction, and is usually intermittent, vague, deep-seated, crescendo, but soon becomes sharp. The pain of intestinal obstruction is disquieting but bearable, in contrast to more small quantity that rapidly becomes unbearable intense. The intensity of pain going with the caliber of the organ. If we have something obstructing the small intestine, it gives the pain. But if we have something obstructing the common bile duct, the pain is very severe and very intense. If we have something in the right side of the colon, the pain is bearable. But if we have something in the sigmoid, the pain is very intense because the caliber of the sigmoid is much less than that of the right side of the colon. Causes of pain. We have gynecological cause of pain. The most common cause in the adolescence is the mid-cyclic pain due to rupture of the Gravian follicles. It's usually mild pain and stays for hours and goes on. We have pain due to disturbed ectopic pregnancy. We have complicated ovarian cyst, which gives a sudden onset of pain. We have complicated fibroid, endometritis, and the most common cause sure is the labor pain. We have to know that we have medical and endocrine causes of acute abdomen, and we have to differentiate these from the surgical abdomen. We are going to pass rapidly on the causes of the medical causes. These are endocrine and metabolic: uremia, diabetes, Addisonian crisis, porphyria, acute intermittent hyperlipidemia. We have hematological disorder like sickle cell anemia, acute leukemia, Hennig-Schönlein purpura, and we have some due to lead poisoning, infection and inflammation of the nervous system that occur in tabes dorsalis, herpes zoster, and we have referred pain due to myocardial infarction. This is very important. Sometimes in old age, patient coming with severe epigastric pain, and we diagnose this as gastritis. And in some cases, it is myocardial infarction. So in the age group above 50, whenever patient coming with abdominal pain, mainly epigastric, we have to consider first myocardial infarction. Don't consider a gastritis or something like that. If you consider gastritis and it is myocardial infarction, it will have a bad end. But if you consider myocardial infarction and they prove to be negative, it is good. So you have to suspect the worst, not the good things. We have non-surgical causes. If we have a baby coming to us with abdominal pain and the pain is not severe, and whenever taking the history, the patient having 2 weeks before 10 days before he has upper respiratory tract infection, we have to suspect on mesenteric adenitis. And how to differentiate mesenteric adenitis from appendicitis? The pain of appendicitis starts periumbilical and then settled in the right iliac fossa. But in mesenteric adenitis we have something called shifting pain. If we press on part of the abdomen and we maintain our pressure and then we let the patient change his position, the pain disappears because the mesenteric adenitis occurs in the mesentery, and however the patient changes his position, the mesentery changes, so the pain disappears. We have acute enteric infections, acute enteric poisoning, we have inflammatory bowel disease and pancreatitis, and one of the most common medical emergencies. Pain usually comes with vomiting. Vomiting is usually secondary to pain. In acute abdomen, acute surgical abdomen, the pain starts first, and then we have a reflex vomiting. This in contrast to medical cases. Medical cases with vomiting first and pain coming after this. So in taking the history of the patient, we have to stress which starts first. The pain started first or the vomiting started first. It is usually not associated with nausea. This in contrast to the medical cases. Medical cases we have nausea first and then vomiting. But in surgical cases it is not associated with nausea. And it may be bile stained due to regurgitation of bile from the duodenum to the stomach. It may be associated with constipation, as in reflux illness, with obstipation, complete cessation of bowel movement. It may be associated with diarrhea, which may be watery or bloody. Watery diarrhea, if we have patient suspecting that he has something intra-abdominal, and the patient coming to us with watery diarrhea. Mostly this patient having a great problem happened inside, perforation happened, and there is what we call pelvic abscess. The cause of watery diarrhea after acute abdomen is collection in the pelvis causing watery diarrhea, and this is very important. Some patient coming with jaundice. Jaundice, if we have patient having a stone in the common bile duct, he will start to have acute abdominal pain. Sometimes this is some vomiting and associated with jaundice and the fever. Hematochezia, this passage of blood with the stool. Hematuria in cases of ureteric stones, in case of kidney stones, the patient having sure pain, and this pain associated with hematuria. And if the patient having family history of medical acute condition like Mediterranean sea fever, we can take this from the history. Endemic areas of hydatid and malaria and typhoid. The most common causes of pain associated with hydatid is infection of the hydatid self itself, and the pain occurs in the upper right abdomen and it is fixed all through the examination. Malaria and typhoid usually have a tender spleen, and in typhoid sometimes you have acute abdomen due to perforation of a small ileal ulcer, and this usually occurs after 2 weeks of the typhoid fever. If we're having patient having typhoid fever and he receives the treatment, and after 2 weeks he will come to us with acute abdominal pain, we have to suspect perforated typhoid ulcer. And this patient had a pathognomonic thing in the white blood count that is associated with leukopenia or normal white blood count, in contrast to other acute abdomen which is associated with elevated white blood count. Most patients, although uncomfortable, remain calm till the end of the examination. The visceral pain patient may be worsening in contrast to rigidity, motionless, peering parietal pain patient. On examination, patient may have pallor, hypotension, hypothermia, tachycardia, sweating. Fever, will be low grade in case of appendicitis, diverticulitis, cholecystitis. High grade when it is complicated or in cases of salpingitis and the tubular ovarian abscesses. On doing clinical examination, as routine inspection, palpation, percussion, auscultation. In inspection we can find the scar in the abdomen denoting that he has something happened like adhesions or obstruction. We have a scaphoid abdomen to guard against the pain. This is occur in the perforated ulcer. We have to look for the hernial orifice because one of the most common causes of acute abdomen is hidden femoral hernia. This is especially in females, and we have to look for localized masses. Palpations. We have to palpate for hernial orifice. We have to ask the patient to take deep breaths to relax the abdominal or the voluntary rigidity of the abdomen. In peritonitis there is all over the spasm of the abdomen, and we have to look where is the tenderness. Also we have to do head elevation that will decrease the pain associated with rectus hematoma, which will decrease that of peritoneal infection. We have to look for appendicular masses in the right lower abdomen, cholecystic masses. We have to look also for the ileopsoas sign in the presence of psoas abscess. We have to look for the obturator sign, and we have to look for shifting tenderness to diagnose cases of acute mesenteric adenitis in children 2 weeks after upper respiratory tract infection. Percussion. We have tenderness on percussion. The percussion itself is tenderness. We have shifting dullness due to presence of some fluid inside the abdomen. If we percuss area having fluid, it is dull. And if we shift the patient to the other side, the fluid will shift and this area becomes after this resonant. And sometimes we have absence of normal dullness. We have normal dullness over the liver, and we have normal dullness over the spleen. In cases of perforated viscous, perforated gallbladder, perforated gastric ulcer, duodenal ulcer, there is free peritoneal air, and this will mask the normal dullness of the liver and the spleen. Auscultations. Early there is normal sounds, later the sound disappears and the abdomen becomes silent. Sometimes we have peristaltic rushes in cases of obstruction to overcome the obstructing segment. We have to do for these patients rectal examination. It will show diffuse tenderness if we have pelvic collection. It will choose one side tenderness if it is due to tubo-ovarian abscess or salpingitis. It may come with blood, mucus, and we may feel masses. This is this introduction for the coming few slides. In order to diagnose patient abdomen, we have to divide the patient into 4 quadrants: upper right and the upper left, lower right and the lower left, and we can consider the flanks and the umbilical area. This is differential diagnosis of pain of the right upper quadrant. Upper right quadrant, they may be right lower lobe pneumonia, retrocecal appendicitis, congestive heart failure, right pyelonephritis, acute hepatitis, biliary colic, or acute cholecystitis. In the lower quadrant, we have, in the left upper quadrant, we have pneumonia, gastritis, perforated peptic ulcer, pancreatitis, and we may have fractured ribs or splenic fractures or ruptures after trauma. In the right lower quadrant, we have Crohn's disease, torsion right testis, right renal colic, mesenteric adenitis, or acute appendicitis. In the right lower quadrant, we may have pelvic inflammatory disease, rupture ectopic pregnancy, torsion of the ovary, or rupture follicles. In the left lower quadrant, we can have torsion testis, left renal colic, large bowel obstruction, inflammatory bowel disease, urinary tract infection, acute urinary retention, or diverticular diseases. In the para-umbilical or peri-umbilical area, we may have ischemic bowel, small bowel obstruction, early appendicitis, inflammatory bowel syndrome, or gastroenteritis. This is the most common causes of acute abdomen: appendicitis, perforated peptic ulcer, intestinal perforation, mixed diverticulum, diverticulitis, gastroenteritis. This is the common causes of acute abdominal pain due to visceral causes: acute pancreatitis, acute calculous cholecystitis, acalcular cholecystitis, hepatic abscess, rupture hepatic tumor, acute hepatitis, splenic rupture. This is the most common causes due to gynecological problems: rupture ovarian cyst, ovarian torsion, ectopic pregnancy, acute salpingitis, pyosalpinx, endometriosis, or uterine rupture. This is the extra-abdominal causes of acute abdomen. Supradiaphragmatic causes may be due to myocardial infarctions or pericarditis. Left lower lobe pneumonia, pneumothorax, pulmonary infarctions, and the hematological causes are sickle cell disease and acute leukemia. Endocrine causes include diabetic ketoacidosis and Addisonian crisis. What we are going to do for this patient, as we said before, the most important is the physical examination. And because of physical examination, we can differentiate between medical causes and surgical causes. The lab examination are blood for CBC, ASR, sodium, potassium, blood nitrogen, creatinine. We can do urine color and specific gravity is stool for blood. Chest X-ray will show raised copula if there is subdiaphragmatic pathology. And the plain X-ray abdomen will be of value in suspected intestinal obstruction. We have multiple fluid levels. Perforated viscous, we have free air inside the peritoneum. Renal calculi, we can see the shadow. Acute cholecystitis, we can see air inside the gallbladder itself or inside the biliary tree. And bowel gangrene, we have air in the bowel wall itself, not inside the lumen of the bowel. Abdominal gas distributions are in paretic ileal and obstruction and the pseudo-obstruction. We have diffuse pattern with air outlining the rectal ampulla. Right lower quadrant ileus in cases of acute appendicitis, some print of ischemic colitis, psoas obliteration, failure of gas to pass, stoppage of gas in the upper rectum, or gas in the portal venous radicals. We can do for this patient also contrast study. If indicated, we should do this using gasographene, not urographene. Gasographene is water soluble contrast, because if we use lipid or fat soluble, if we inject this, it will cause some form of severe allergy. So we have to use water soluble contrast in the form of gasographene. We can do ultrasound examination, CT abdomen, radionuclide study, endoscopy, and paracentesis if there is free fluid inside the abdomen. Now, as we said before, we have to differentiate between the surgical cause of acute abdomen and the medical causes. And for us, the most important thing is the medical examination. X-ray abdomen will help us, X-ray chest will help us, but the most important is to differentiate from our physical examination. How to differentiate surgical causes from non-surgical causes. Surgical cause usually associated with abdominal pain for less than 24-hour duration. The patient is septic and looks toxic. The abdomen is board-like. This in contrast to non-surgical causes. Usually non-surgical causes, the abdomen is soft. If you examine patient with surgical causes, the abdomen is board-like rigidity. There is tenderness, there is rigidity in one side, soft on the other side. But in cases of medical abdomen, all the abdomen is soft. And by this way, we can differentiate between surgical causes and the medical causes. So examination is the most important. Absent bowel sound usually occur, but this usually occurs late in the progression of the septic condition of the peritoneum. And the white count is raised and may reach 25,000. And we have to look for X-ray chest, because by X-ray chest we can see the undersurface of the diaphragm. If we have free air under the diaphragm, this means that we have perforation anywhere, maybe perforated intestine, maybe perforated appendix, maybe perforated gallbladder, and this is a surgical emergency. You have to take patient right to the OR to eliminate the cause of the free air under the diaphragm. This is the non-surgical causes. The pain is trivial, small amount of pain, mild pain, and it is not continuous, maybe 1 hour, 2 hours, and then disappeared. And this post appearance of the patient, the facial characters is the same, not changing. This in contrast to the surgical cause of pain. The visual pain score for this patient is increasing, and in medical case it is not increasing. The abdomen is soft, there is no guarding. Sometimes there is mild tenderness, but sure there is no rigidity. Rigidity means inflammation or irritation of the parietal peritoneum. In most cases of surgical abdomen, there is irritation of the parietal peritoneum. That's why you have rigidity of the abdomen. But in cases of medical conditions, there is no irritation of the parietal peritoneum, and the abdomen is soft all through the examination, all through the pain suffering with the patient. The white count will be normal, and the abdominal sound is normal, and the upright X-ray of the abdomen is usually normal. Again, the most important thing to differentiate between acute abdomen, surgical and non-surgical, is the condition of the abdomen. It is soft in the non-surgical cases and it is rigid in the surgical cases. And by the X-ray chest and X-ray abdomen, you can see some of the intra-abdominal pathology. Now we diagnose the patient as surgical cases. So we have to admit the patient. What is the criteria for admission? Any patient with acute abdominal pain for more than 6 hours not responding to medical treatment must be admitted. Localized pain and tenderness. Localized pain and tenderness means there is intra-abdominal pathology. But if the pain is vague, the tenderness is vague, this means it is not surgical case. But localized pain means that there is localized cause of pain, and this in most cases is surgical cause. Diffuse tenderness and the general rigidity. If we find a patient having a board-like rigidity, all the abdomen is like that, this means there is irritation of all the parietal peritoneum, not localized to one area. Usually we see this in perforated gastric and duodenal ulcer. As you know, it started by chemical peritonitis, and at that time we have board-like rigidity. After some time, this neutralization to the content of the perforation, and at that time the abdomen more or less becomes less tender. After this, we have the septic or the infectious peritonitis. Again, the abdomen becomes back board-like. It started board-like due to chemical peritonitis. After neutralization, the pain and tenderness decreases, and whenever we have infection of the content, there is diffuse peritonitis. If in doubt for pain, we have to consider the most common causes, which is appendicitis till proved otherwise. And as we said, in the old age group, having pain in the upper abdomen, we have to consider myocardial infarction till proved otherwise, because we are going to lose the patient within 2 hours if we didn't do a good selection of the case. If it is proved acute myocardial infarction, it needs urgent ICU admission. Free or abnormal air under the diaphragm denotes there is perforation. Air outside the bowel wall needs also perforation. Air within the portal or radicals means there is insult in the biliary tube. Indication for urgent operation. From the physical findings, there is involuntary guarding or rigidity, especially if spreading. It starts in one area and becomes diffuse, and all the abdomen becomes tender, and there is rebound tenderness also. Increasing or severe localized tenderness, tense or progressive distensions. We have to take care of this one. If we're having a patient having tense or progressive distension, and the pain may be not too much, they may be due to, if you look to the sigmoid, it is have mesentery, and sigmoid colon is the most liable organ to do torsion. And if we have torsion of the sigmoid, there is failure to pass the air, so the intestine becomes progressively increased in size. So the abdomen becomes distended, and this one will lead to elevation of the diaphragm, splinting the diaphragm, and the patient may pass into respiratory impassment, and you call this abdominal compartmental syndrome. Abdominal compartmental syndromes mostly due to torsion of the sigmoid, and at that time we have massive distension of all the intestinal loops. The small and large, the diaphragm may be splinted, and the patient may pass into respiratory disorder. Regarding the radiological finding, we may have pneumoperitoneum. Pneumoperitoneum means free perforation. We have, if we do for this patient any contrast study, and we have extravasation of the dye, and I said before, we have to do this contrast using water-soluble agent like gastrografine. If we see extravasation, means the dye goes outside the lumen of the bowel, there is perforation anywhere in the gut. If we have space occupying lesion with fever and there is tenderness, this may be the perforation or due to necrosis of this lesion. If we have mesenteric vascular occlusion on angiography, and this is very rare and we will not face this one. If on endoscopic finding we have perforation or uncontrollable bleeding, if on paracentesis there is blood, bile, pus, bowel, or bile content. Thank you. Now the problem for us, if you are working away from the hospital and you're having in your clinic a patient coming with acute abdomen, what you are going to do for him? If you are alone, what is the first thing? As we said, the most important thing is differentiate between surgical cause and the medical cause. We can differentiate this without doing anything to the patient, except the medical examination. From the history, if he has recurrent attacks of such a condition, if he has a family history, mostly it is not surgical. Because the current attacks is not a surgical problem. If he has a family history, mostly it is not a surgical problem. If this pain comes to the patient for the first time, it is increasing pain, localized pain with tenderness, it is mostly a surgical condition. Regarding the, maybe you are going to work in a place there is no CBC, no chest X-ray, no X-ray abdomen, nothing. You have only the physical examination. At that time, you have to observe for 2 hours for the patient. Don't give analgesics, because analgesics, this is very, very wrong and very dangerous. May mimic the pain. The patient may have analgesics and to go home is comfortable now, and the process is going on, running on. If he has perforation, if he has appendicitis, cholecystitis, and he receives anti-inflammatory non-steroidal, now he will not suffering from pain. So the bad thing is to give the patient analgesics. You can give analgesics when you are sure 100% it is not a surgical cause. Because if you give analgesics to the patient and he goes home and the process is running, maybe he started by having appendicitis and end by having generalized peritonitis. So don't give analgesics to the patients. You can give the patient antispasmodics. The most common causes you will face with is appendicitis and intestinal colics. If to give the patient of intestinal colics some antispasmodics, maybe he has some relief. But the patient of appendicitis will not have relief by the antispasmodics. If they give the patient of the intestinal colic analgesics, he has relief, and also the patient of appendicitis has relief also. So it is very dangerous to give the patient analgesics and ask. You can give analgesics while the patient inside the hospital, but don't give the patient analgesia and let him go except you are sure that this is not a surgical case. In the old age group, you have to suspect the worst, this myocardial infarction. Many patients coming to the ERs and they have epigastric pain diagnosed as a gastritis, something like that. He given something like Mucain, like Zantac, Bentazole, and he goes home and he died at home. This because he has myocardial infarction and it's missed. So you have to suspect in the old age group, the first thing is myocardial infarctions. Patient coming to us having pain in the abdomen and pain in the back. Severe pain. We have to think of pancreatitis. Pancreatitis usually coming with epigastric pain and the pain in the back. And if you ask the patient to lean forward, the pain will decrease. This patient of pancreatitis usually coming shocked. So you have to insert IV cannula, give the patient fluids, give him analgesics, till you transfer the patient to another place. Patient having acute cholecystitis. Usually we see this in females, and usually sometimes you see this in pregnant females. This is very important. You have to differentiate between acute cholecystitis and acute appendicitis. The differentiation from the history of this is acute appendicitis, usually it is the first attack. When acute cholecystitis, the patient having history of stones before, he has recurrent colics, recurrent pain, and pain referred to the shoulder. This indicates acute cholecystitis, not acute appendicitis. In case of gastroenteritis, if you confront a baby to 2 years, 3 years, 4 years having a case of gastroenteritis, and he is coming after 2 days, 3 days with abdominal pain, with distension, we have to suspect of the most common cause is intussusception, because of the enlarged lymph node will act as the head and start to have intussusception. Patient having something like hydatid cyst in the liver, and this one never come to you for the first time, because the first time it is painless. Whenever he came with this, maybe patient coming with anaphylactic shock. The first thing is to give the patient high dose of corticosteroid. You may give him 100 milligram every 2 hours, and you have to admit the patient. Okay? Any questions? حد يقول لي كده شاف عيان قريب اكيوت ابدومين عمل له ايه؟ يا جماعه اوكي when dealing with acute abdomen, you have to consider that you are going to differentiate between medical cases and surgical cases. Medical case you can give him antispasmodics and observe him for a time. If he becomes okay, he can go home. Surgical cases will never be improved by giving antispasmodics. So you can do what you are saying. You can insert for him cannulas, but if you are going in a remote area, you don't have ultrasound, what you are going to do for him? This is the problem. If you are working here in Cairo, in Giza, you can transfer him to any hospital. The problem is that you are going to work in a remote area. You don't have anything except you and the nurses like that in any place. So the problem for you is to know this is surgical case or medical case. Okay. Also in dealing with the old patient, and we have here a big incidence of diabetics. Patient with diabetes usually coming to us late because the pain threshold due to neuropathy is decreased. Maybe you have acute appendicitis, any intra-abdominal condition, days before, maybe 1 week before, he's coming late. So in patient with diabetes, we have to transfer him direct to the hospital to do at least ultrasound abdomen. Any question again? Huh? Okay. Still the same. And this is very important, because there is irritation of the parietal peritoneum, and the analgesics will cause nothing for the irritation of the parietal peritoneum.